at the meeting in Galway, you mentioned the fact that if we are going to reduce the burden of illness related to osteoporosis in Ireland, we need to educate and enable patients to make appropriate changes to their lives. How can we try and achieve this goal?
So one of the first ways to achieve this goal is to sit down and explain to patients, if you have a fracture, that means a broken bone. Lots of patients, just like when I was a student in Dublin, UCD in the 90s, patients said they were lucky it wasn't a cancer, it was just a tumour. But to all intents and purposes, it's the same thing. So using the correct terminology, patients need to understand that a fracture is a broken bone. So that's the first thing. And then the patients need to be given the right information, what the broken bone means. This means you have osteoporosis. This means your bones are weak. And this means you're more likely to break another bone. We talk to patients and we explain about general lifestyle changes, things like good lighting in their hallways, having the ends of rugs taped down so they don't trip and fall over them, making sure if it's very windy or frosty outside that's not the best day for them to be going out for a walk. That's probably the best day to stay at home in the safety of their own home, and things like that. We talk to them about additional tests they may need that will help qualify what treatments would be best suited to them. We like measuring vitamin D. We make sure they have enough calcium in their diet. Diet is better than supplements. If they're not able to eat enough calcium for whatever reason in their diet, we may add calcium supplements. But calcium and vitamin D supplements on top of a normal intake actually increase fracture risk. They don't decrease fracture risk. So a lot of it's around removing medicines they don't need and not getting them on things that don't work or may actually be harmful. And then finally, we talked about the medications. We explained the medications are generally very safe and very effective and best suited to people who already have fractures. Although everybody's got concerns about side effects, the biggest side effect is no treatment and dying following a fracture, not the side effects of the medication. Unfortunately, like any medicine, inevitably, some people will get side effects, but that thankfully is the minority of people. And then we explain to patients that they need to follow up to get a DEXA scan to monitor the treatment. It's no longer for diagnosis, it's to monitor their treatment and to follow up with their doctor. So we have a very good fracture liaison service in the hospital run by two nurses, Fiona Heaney and Catherine Armstrong, and they have a booklet and they spend time with the patients and go over all of this. And we send a letter out to the GP to make sure the GP is the correct information following the hospital admission, because less than 20% of people, as I say, have the right information from the hospital discharge. So we follow that up with a letter from the osteoporosis service to clarify any misinformation that went out. Ideally, for a lot of these patients, as you can imagine, they have other medical problems, and more tablets, more confusion is often seen as the problem, but in actual fact, it's keeping it simple, keeping it clear, and keeping it short is the best message for these patients. Some of them have cognitive impairment, so they can't understand complex medical regimens. So we keep it as simple and as clear as possible.
Let's look at one particular age cohort. I think, again, as you mentioned, at your talk in Galway, many over 65s aren't being diagnosed or treated for osteoporosis. How can this problem be addressed?
So again, this problem is easy to address for people with fractures. All the doctors and nurses in Ireland and the patients and their relatives need to know, if somebody is admitted to the hospital with a fragility fracture, they have osteoporosis. And if it's not osteoporosis, it's some other bone disease, but it's not normal to trip and fall and break something, or to cough and sneeze and break something, or to break a bone in your back putting on your shoes. That's not normal. That means you have osteoporosis. So that is the fundamental message. Once we get that across, there's a cascade of events that happen and a variety of things that we don't always know about that will help reduce the risk of future fractures. It's very important that a lot of these older patients admitted to the hospital are also seen by medical people. Historically in Ireland, we have a very antiquated medical system, is probably the nicest thing I can say about it. But they're still admitted under orthopedic surgeons who are excellent surgeons, but they're not excellent physicians a lot of the time, and they need help from the physicians like myself to co-manage those patients. So in the best hospitals in the world, and the international standards are out there, and there is a new group, a fracture liaison service group in Ireland that are working nationally with orthopedics to provide the best physician support for managing the comorbidities, reducing the risk of falls, educating the patients and getting them on the right treatment before they leave the hospital, along with the surgeons to provide the best surgical services for those patients. All the international evidence shows you reduce the length of stay, you improve the diagnosis and the treatment, you reduce inpatient mortality, and you reduce the likelihood that those patients will end up back in the hospital with another fracture in the next 5 to 10 years. So that is one really important strategy.